Good morning. My name is Keith Lamb, and I want to welcome you to our second live panel discussion brought to you by Inspire Respiratory Critical Care. I'm going to introduce myself, and then I'm going to ask all of the moderators of the panelists to introduce themselves. My name is Keith Lamb. I'm a respiratory therapist. I practice at the University of Virginia on the surgical, neurosurgical, and trauma service. Eric?
Thank you. Hey there. My name is Eric Kreiner. My day job is adult critical care clinical specialist at MedStar Washington Hospital Center in Washington, D.C.
Tom?
My name is Tom Pereno. I'm a respiratory therapist in Canada, and I'm a consultant and educator. We'll go with you, Joe.
Joe?
We'll go to Joel. There you go.
We'll go to Hello, I'm Joel Brown.
Joe Hilton. My day job is clinical applications. I'm sorry.
It's okay.
Go ahead, Joe.
Go ahead, Joe.
Joe Hilton. Day job is clinical applications for Hamilton Medical. Other hours job, I still do critical care transport and ECMO at the local trauma center here in North Carolina.
All right, Joe.
Joel Brown. I am the chair of the Leadership Management Section, CEO of Arrive Leadership, former role, hospital administrator.
Andy?
Hi, Andy Klein. I'm the clinical education coordinator, also an assistant professor. I work at Rush University Medical Center in Chicago.
Madison?
Hi, I'm Madison Fresky. I'm a respiratory therapist at UVA in Charlottesville, Virginia.
And Brady?
Hey, I'm Brady Scott. I'm an associate professor and a program director at Rush University in Chicago.
All right. Did I miss anybody?
I don't know if Pablo's microphone's on. I don't see a video.
Well, Pablo Gonzalez is here today. He is the person who submitted the question du jour, or the topic du jour, and that topic is pro-cons of electronic impedance tomography and esophageal manometry. So that's what we'll discuss today. I appreciate all of you showing up for this important topic. So I'd like to start with Tom Pereno. Do you want to give just a little overview of EIT and esophageal manometry?
Oh boy. All right. Put me on the spot. Well, I'm assuming if you've signed up for this webinar that you're at least familiar with at least the general concept of the two. Electrical impedance tomography is basically, it's a monitoring tool. It's a device that you can get in most countries now. Depending on the device, you may not be available in your country. For example, the most common device in Canada, the only one available for market, is the Draeger Palmavista, which is not available in the United States. But in the United States, you have the Timpel device, which is available, and they're out of Brazil, and of course, Draeger's out of Germany. So with these devices, you get a band that gets applied to the patient's chest. It gets applied between the fourth and fifth intercostal space. And what it has is leads that situate itself around the chest. Depending on the device, the Palmavista has 16 leads. The Timpel has 32. There's not a huge difference in the quality of the image. All the images are reconstructed to look nicer on the screen than the actual pixels that they generate. But essentially, it sends an alternating current around the chest. It's a very small current. It's not felt by the patient. And it sends this current around the chest in 50 cycles per second. It creates an image. And it's a little bit harder to describe without a picture what it does. And I can bring a picture up if someone else wants to comment in a moment. But essentially, it constructs an image, and then it constructs the image of the chest, measuring the impedance of air. So again, as the electrical signal gets transmitted across the belt and across the chest, it sees changes in impedance, which is essentially the resistance to the current, and it measures the change, and it shows it as essentially air moving in and out of the lungs. And by doing this, you can see ventilation distribution throughout the lungs. Now, with this ventilation distribution, you can measure things like regional compliance changes as you adjust the ventilator. And this is probably the most common use with the device, is to see how ventilation throughout the lungs change when ventilator parameters are changed. It's often used for setting PEEP, etc. So that's a very basic overview. Obviously, we'll get into more details. And like I said, I can bring up some images. Esophageal pressure manometry is simply an esophageal balloon catheter placed into the esophagus of the patient. The balloon portion of the catheter should sit in the lower third of the esophagus, essentially behind the heart. And what this does is estimate or represent pleural pressures, which are the pressures outside of the lungs. And its most common use case traditionally was for looking at things like asynchrony, and then for setting ventilator parameters such as PEEP, and limiting plateau pressure based on the pressure that the lung actually feels. So if you have pleural pressure, then you can measure transpulmonary pressure, which is airway minus pleural pressure. Again, it's an estimate. It's the closest thing we have to actual pleural pressure. It is regional, meaning it's in the center of the chest. It doesn't represent, I shouldn't say regional. It's a sort of a global, where it's positioned. It doesn't represent the dorsal regions or the ventral regions per se with just the catheter, but there's different measurements you can do to represent different areas of the lungs. If anyone wants to add to that, I'll call up a picture of the EIT, the belt and the signal.
Eric, did you want to add on to that?
No, I think that's pretty great description of it. You know, and it's, you know, I think that the conversation would be an interesting one, you know, depending on where it goes to, because clearly these are either specialized pieces of equipment, and certainly the esophageal manometry requires some skill set to go along with it, right? And so, you know, what's interesting is, as you speak to, you know, a larger audience who may not have those at their bedside or in their institution, you know, how does all of this fancy stuff compare to what everybody has, right? You know, and so, you know, we use both of them, you know, in conjunction, separately, for an entire data set, for an entire kind of assessment of the patient, and you know, guide our PEEP and our volume dosing accordingly. So we are fortunate that we have both of them. So I think the other tools that we have, and you could probably argue even esophageal manometry, but I think what I'm referring to is driving pressure or best compliance when we're talking about PEEP. But just in general, they're really blunt instruments, right? That represent an entire, they're giving you one picture for the entire lung, right? Where we know that there's heterogeneity and there's regional differences and such. And I think, you know, the most exciting thing about EIT is it's able to separate out the regional differences and become a much more exacting tool as opposed to a blunt instrument, you know, and we'll see where it goes. I think that Tom's group, that their publication of the interim analysis of the COVID patients, and how driving pressure was clearly demonstrated as pretty blunt, right? It was off in a lot of patients. So
yeah, essentially the best compliance is something that's confused people for a long time. We assume that the better your compliance is, the better off your lung condition is. And what we've realized with EIT over the years of using it is that at the moment you have your highest compliance, you may also have a large degree of collapse going on. And what you have is tidal recruitment. So the lung is opening up when you apply pressure, but this nice compliance doesn't necessarily represent a lung that is optimally positioned to either balance over distension and collapse, or to just limit collapse in general. So the whole idea of setting PEEP, for example, using decremental PEEP trials and using the best PEEP or the best compliance, may not actually represent a good balance between the lungs. And this is the same with driving pressure. You know, if we think about going, you know, if you think you want the lowest driving pressure possible, that's never been clinically what I would try to do. I would try to limit my driving pressure, try to get it to less than 15, but whether it's 14 or 9, I'd honestly feel more confident with it being 14 than it would being 9 if I was doing a PEEP trial, because I know that the lower my driving pressure is, the higher my compliance is, and I may actually have more tidal recruitment happening. So this atalic trauma that can happen. And EIT's really sort of opened our eyes for that over the years. And just to quickly comment on this image here. So this one here is just showing you, this is what you would see when you get an X-ray. And just to point out that EIT is more like a CT slice. So it's not this type of view, it's that type of view, right? It's a caudal cranial view. So you're looking from the feet up to the head like a CT slice. These are the leads that go around the chest. And basically, just to briefly describe it, it starts off with the lead, the main signal coming from lead 1 and these pairs here. This is lead 1 and lead 16. This is an example of the Palma Vista. It sends the current from lead 1 to lead 2, and then lead 1 to lead 3, etc., all the way around the chest. And each time it does that, each pair of electrodes compare the impedance from the main point. And after it goes around once, it then jumps this main one over here and does the same thing over and over again. And you get 50 cycles per second. And that's why so with one cycle, you get one image generated with EIT, but because it's doing it 50 times a second, it's an animation. So this video is really an animation of 50 images per second, and that's what you're seeing. And of course, as you make an adjustment, it's immediately reflected in the EIT image because it's doing this imaging 50 times per second. So and in terms of placement, you place it between the 4th and 5th intercostal space there. Go ahead, Keith.
I was just kind of, so it's a good point that Eric brought up in terms of the bedside clinician in a small non-tertiary medical center that may not have any of this available. If you remember about 23 years, and in terms of this being a blunt instrument, if you remember about 23 years ago when the ARDSNet ARMOR trial came out and we started to sort of blindly follow this 6 milliliters per kilogram predicted body weight of tidal volume. And then several years later, we realized that maybe it's not the volume, it's the volume in relationship to the available space in the chest for that volume. And then we started talking about driving pressure more recently, and now energy, mechanical power, equation of motion, and all these really high-end things leading up to the development of this imaging now. So if you go all the way back to, okay, we were just using smaller tidal volumes or controlled tidal volumes to now looking at specific imaging of the chest. What do we anticipate are going to be the advantages other than, obviously we have more data available to us now. I've used esophageal balloons for quite a few years now. What do we think all of this is going to translate to in terms of outcomes? And why, if I'm a bedside clinician at a small institution and I don't have either one of these things, why should I fight for one or the other? And if I was going to fight for one or the other, which one would I fight for? Joe?
I mean, I was going to say someone else could comment. I'll add some sort of comments to the end of it.
I guess I'll talk a little bit about, especially when you talk about ease of use at the bedside, and from using both. I can tell you that I've always found that the esophageal balloon was easier. Although I felt like you get a ton of data. And when I used the EIT, it was when it first started. It was a prototype, the Draeger version. It was actually on a Draeger XL screen and a big old computer attached to it. And although the band was easy to put around, I found that it actually required us to have a whole lot of other people involved, meaning had to turn the patient, had to move the band, had to make sure it wasn't on but so long, and those types of things. So it had nursing and everybody else actively involved constantly while we had it in there. Whereas, at least from my personal experience, when it came to dropping the esophageal balloon, although I had my one single bedside nurse there, usually it'd be putting it in, and other than that, it was pretty easy to do. The other thing is that, the EIT part, where we had difficulty, at least, that would make me say that the esophageal balloon, for again, this, you're talking about a place that has never done either, trying to figure out which one do I use. It took a whole lot more to get a whole new device brought in, whereas, you know, you can get esophageal balloon built into certain, depending on what ventilators you use. So if it was just strictly about ease, and I'm a new small hospital, it'd be those. Because number one, I need to train the respiratory therapist how to use it, and pretty much after that, just let nursing know, you know, give them some, you know, inform them about the type of catheter I'm using. Versus EIT required us to train a whole lot of people, keep a whole lot of people informed, and a lot of movement of a patient that was fairly critically ill. That's just my 2 cents.
Joe, did you have anything to add?
I agree with Joel. That even esophageal, if you don't do it a lot, it can be a very challenging process for folks. If it's one of those low volume, high risk type things, usually getting the catheter in place is the hardest part of it. And then if you do one every 6 or 8 months, you've only done a handful of them. It can be challenging as well. But it's the easiest of all three, I think. If you look at esophageal versus the whatever recruitment tools may be on some machines versus EIT.
I think it's definitely the easiest now in terms of accessibility, right? I mean, obviously the EIT device is going to be thousands of dollars and not everyone's going to have it. Once you have it, it's pretty easy to apply. I agree with Joel. You do need an extra set of hands typically. I can easily get the device on with one other person helping me. If you're first starting out, it might take, you know, maybe 3 of you to really get it going. But once it's on there, there's really not a lot of technique involved, right? The device kind of does what it does once you set it up properly. Esophageal balloon, there's a bit of a technique. There's positioning, ensuring it's in the right position, doing the modified Bader maneuver, making sure you have the right filling volume of the balloon catheter. Like, there's a lot of opportunities for things to go wrong with balloons. Even the coiling in the back of the throat. I've had some people do measurements where they're getting numbers. The numbers may not make a whole lot of sense, but they're getting numbers and values and they're documenting them. And then you realize the catheter's been coiled at the back of the throat and the balloon's really only sitting right about here. So there's really a lot of opportunity for messing up esophageal pressure measurements. And interestingly enough, as more data comes out, you know, even published by colleagues of mine, I'm really, in terms of setting PEEP, I would highly recommend using an esophageal balloon catheter to set PEEP in an obese patient. When it comes to general monitoring of patients and the safety of ventilation, in terms of, like, you know, how high a plateau pressure you should utilize, driving pressure is outperforming transpulmonary pressure measurements in terms of safety of ventilation. So for setting PEEP, I still think it has a role. For limiting lung stress and strain, driving pressure still outperforms it for the majority of patients. And I can share some images. Let me just bring up a paper by a colleague of mine, Dr. Lu Chen. This paper here was published in Intensive Care Medicine. Let me just scroll down a bit here to some of the Kaplan-Meier graphs. So they compared, let me just zoom in a bit. They compared driving pressure less than 15 and driving pressure greater than or equal to 15. And there's a clear survival difference between these patients over time. And when they looked at transpulmonary driving pressure, just looking at, you know, whether or not transpulmonary driving pressure offers more value, you can see there is a separation, but it's not stronger than regular respiratory system driving pressure. So if you're considering it as a tool to better understand the safety of ventilation, it doesn't really outperform driving pressure, it appears. When it comes to the elastance-derived transpulmonary pressure, which we can get in a discussion later, but this really represents more of the ventral regions of the lungs. It's why it's used sometimes in conjunction with other esophageal pressure measurements, because when you calculate the elastance-derived transpulmonary pressure, studies have demonstrated that it represents the baby lung, the already open region of the lung, the ventral region. And when they limit that to less than 24 versus greater than or equal to 24, again, there's some separation there, but there's quite a bit of overlap. So again, it's not as useful as driving pressure per se. And then just looking at directly measured transpulmonary pressure. So making sure that PEEP is set, less, if it's set less than 0 or greater than or equal to 0 transpulmonary pressure at end exhalation, there was no again, distinction for mortality. However, they did look at obese patients and found it to definitely be beneficial. So if you had to choose which patient to use an esophageal balloon catheter in, I 100% would always prefer one to be placed into an obese patient for the optimal setting of PEEP. Once PEEP is set optimally, driving pressure really can help guide in terms of the safety of ventilation and whether or not you should consider using lower tidal volume or not. Okay, here. Oh, someone's asking for. Someone says, "Can we get the title of that paper?" Sure. Let me just go to the top here. I'll share it one more time. There it is. I will put a link to in the chat for the for this article. I'll just copy this here, and this should work.
Brady and Andy, do you either of you have any perspective on? Well, I know you have a perspective on it, but how do you know? What do you teach now about either one of these two things? And in general, how do you know when to start teaching things? What level of evidence needs to be out there, if any, to start just discussion in the classroom?
Sure, that's a good question, Keith. First, I just wanted to comment the fact that Joel Brown has a bird mark 7 just right over his right shoulder. I can't unnotice that it looks like that's in his home office. So I think that's pretty cool. So these concepts kind of are woven into curriculum as they relate to things like ventilator-induced lung injury and strategies to kind of more of a bigger picture strategy of how to not injure somebody while they're on mechanical ventilation. So you probably are not surprised to know that we spend quite a bit of time teaching students about things like attic trauma, barrel trauma, body trauma, and the various ways to mitigate. And then, so we're a graduate level program. So we actually do spend some time talking about the level of evidence about things like esophageal manometry and EIT and things like that. But in terms of, and it's certainly covered in the curriculum, but in terms of, it being a competency or something that we're checking off for students to go to the bedside, that varies. In reality, some of our students may go to a place like here at Rush, and they could expect to see esophageal manometry being used in a way that Tom, I think, was mentioning in our some patients, in obese patients that may need it for PEEP titration. But they may also go to another hospital where there's not an esophageal balloon to be found, and EIT, most of the people don't even know what it is. So for the sake of time, then we have to make a decision of what exactly are we going to be, checking our students off on and preparing them clinically. And so we really make sure that our students are prepared to do things that we know they're going to be doing quite a bit of, mechanical ventilation, and helping to understand plateau pressures and things like that might relate to ventilator-induced lung injury. But when one puts that into a curriculum, that's not hard to do because you can cover that in various ways, in the many ways to reduce lung injury. But the question is, when do you check off on it? Like when do you make a lab on it? When do you do that? That's when it becomes, we start to realize that it's becoming more and more frequent in our, clinical practice, especially in our region. And we depend on things like our advisory committee and feedback from the bedside clinicians around Chicagoland to help us inform us whether or not the students might be seeing at the bedside. So it's a very verbose answer to the question, Keith, and I apologize for that. But it's really not easy to, every time something new is introduced, to just immediately add it to the curriculum. You kind of have to sit back and see whether or not this is something that, you may see at one hospital, you may not see the other, or, this is very, very common. Like, for example, prone positioning, right? So, prone positioning, not new, has, since 2013 become more and more of a primary way to help manage ARDS in terms of somebody with hypoxemic respiratory failure. So this is becoming much more part of our curriculum in terms of how to do it, how to monitor it, the data behind it, because the literature is really supportive of it, at least for now. And then we also had a lot of experience with it during COVID. So it's really not an easy answer, Keith. We just have to sort of evaluate it as it comes through to see whether or not our students will be using it over and over. And then, and if they are, we'll add it into our curriculum, or at least make sure they are aware of the concepts.
And this question came up regarding staff. So, students is one thing. It makes sense to limit exposure to students, but then what about staff, your RT staff? So for those that have EIT, I mean, my personal recommendation is obviously all staff should be trained on how to use a device, but when you first implement a device, I think choosing sort of a super user group, a group of people that really want to dedicate their time to being able to basically be an extension of you. If you're an educator or, if you're some sort of educator in the clinical setting where you need to educate staff to use it, get a super group of users that can be an extension of your ability to train the staff so that you have people excited to do it. So that would,
right.
Not necessarily a specialized team, but at least, it starts off sort of a specialized team, just a number of people that are willing to sort of put the time and effort to really understand how to apply it and how to interpret the data. And then they can sort of help disseminate that knowledge. Every time they put it on, they can bring in staff that aren't as familiar. But get that core group. And I'm assuming most of you probably would have a similar approach.
Well, I think that, Tom, you make a good point. And I think that, one of the things it's a high, I don't want to say high risk, but it's you do it infrequently. But when you do it, it's on the sickest patient. So having that more of a core group is probably a good approach. I think I will tell you that I am not sure I trust myself right now with placing an esophageal balloon because I haven't done it in so long, but reading the numbers is different, right? So I just think there has to be some specialization. But what I think you can do, though, is you can train more of the masses, the larger groups on, again, these concepts that we don't really debate so much about like ventilator-induced lung injury, right? Have them being aware of, hey, listen, if you're, for example, your plateau pressures are getting to this point, then we need to we need to alert the group. If we're noticing this is happening, then we need to alert the group. And I think that's a reasonable way to more train either your RT students or your staff, is for everybody to recognize patterns that may prompt the conversations of EIT or the need for esophageal manometry or whatever. So I 100% agree with Tom. I think it's like maybe focusing on a super user group, but then also having some, with lack of a better word, some guardrails or some sort of limits in place to say, hey, it's time to start having these conversations with these teams now, way before it gets into rescue mode.
Yeah. And this translates into esophageal pressure measurements as well. Like obviously not just EIT in terms of having a dedicated
100%
first and then, yeah. So we have another question here. And I mean, I can comment on this one because I've been using it clinically, like not just research or not just prototype. Like Joel's probably touched a machine way before I did, but as he mentioned, it was a prototype, probably wasn't very nice looking. But I've used it clinically since 2013. And, I can say that currently there is no data that it's going to change your outcomes because we need a properly designed randomized control trial that utilizes EIT in a specific manner to show this. So some of the limitations right now, you can find randomized controlled trials of EIT online right now, but there's the two ones that I can think of automatically. Both of them only used EIT once on day one to set PEEP and then manage them differently after that. So that right away, you have to look at the methods when you look at the data out there to say, okay, if I use EIT once on day one to set PEEP, and then I use a PEEP table after that, does that mean that EIT doesn't help setting PEEP? Again, this is something that probably you should at least guide the setting of PEEP using EIT at least more than once if you're going to say that EIT actually helps. So that's the main limitation right now of these studies. Another study is just completely underpowered to actually show benefit because they had a very high assumption of the mortality benefit of EIT based on some retrospective data they looked at. So really, it wasn't beneficial. So we don't have the mortality or length of stay data as it stands currently. We have a number of studies demonstrating how PEEP can be optimized and can distinguish recruiters versus non-recruiters. So we have the data that it's physiologically appealing. And you know what? It's the same thing with esophageal pressure right now. The data that we have right now, in terms of the large randomized trials, the trials themselves don't show that there's a benefit to using it in terms of mortality or length of stay. Having said that, when they do post-analyses, they find that, if your esophageal pressure targeted at end exhalation is within +2, there's a benefit for those patients. But again, that wasn't the protocol for that study. So I do believe the EP-Vent 3 is occurring. This will be the third randomized controlled trial of esophageal pressure measurements. And what they're doing, it's almost like, so to me, what's happening with the EIT literature, the esophageal balloon literature, is basically what happened with the prone positioning literature, right? Over time, you just kind of perfect it to the point where you get that magic protocol of prone positioning where you have a significant change in outcomes. And what's happening with the esophageal balloon studies is that over time, they're basically changing their methods. So for example, the first study allowed setting PEEP at end exhalation a transpulmonary pressure of 0 to +10, I believe. And they limited inspiratory transpulmonary pressure to an absolute value of 25. Well, when they looked at the data, they found that people over a plateau transpulmonary pressure of 20, they didn't do too hot. And they also found that this could have been because they were setting end expiratory transpulmonary pressure excessive, +10, instead of just matching your transpulmonary pressure at end exhalation of 0. So the next study, they limited it 0 to +6 in terms of setting PEEP, and the inspiratory limit was 20 instead of 25 for transpulmonary pressure. Again, they found no difference in outcomes. When they looked at the data again, they found that, if you're within +2, there's a benefit. So maybe going to +6 is not good. And I have a feeling they're probably going to adjust the upper limit for inspiratory transpulmonary pressure as well. I have a feeling it's going to be something lower, like a transpulmonary driving pressure, for example, of maybe 10 centimeters of water. So with EP-Vent 3, they're going to revamp all of that and hopefully perfect it to the point where they may be able to say esophageal pressure guided mechanical ventilation is beneficial. But right now, we actually don't have a randomized controlled trial that tells us that esophageal pressure measurements or electrical impedance tomography measurements save money or change length of stay. Right now, it's still a highly nerdy physiology tool at the bedside. It does tell you a lot about your patients. Anyone using it feels that they guide mechanical ventilation with more confidence, but we don't have the clinical data to suggest that there are benefits or outcomes. So we still need proper studies to be performed.
So I'll jump right in on this. Actually, Brady, it's good you noticed this that IPPV machine. It's because I kept it in my office also when I was working as an administrator, and I used it as an example of a device used that didn't have evidence. So anytime someone would come in and say, I want to bring this in, I'd always say, you know what that is? And I'd explain how I used to walk around with that and go from patient to patient every 20 minutes post-op. And then later we found out it had no impact, right? So the reality, I guess, if you want to absolutely get down to it and without sugarcoating it, 3 things are going to get your administrator to do something. It needs to make money, have evidence, or you better have a really good medical director that's supportive of it and believes it's going to be ground setting. Like you're going to be doing something new, something before the evidence gets there. And if you don't have one of those 3, you're usually going to struggle to get it, especially if it's going to cost capital. So either you're going to need to say, I have this is a procedure and it's going to make money. Let's think about that. You're going to get that, right? Next one, you come in and say, hey, there's tons of evidence. This is a great tool. It's going to make me better at the bedside and it's going to make the outcomes for our patient so much better. Okay, you're going to get it. But we know that these devices, they don't have either, right? Both of those eliminated. Right. So the only thing you're going to be able to, the way to get it is, and I see Tom, shaking his head because this is probably what Thomas probably had was a medical director or some physician support, some clinical support that can walk in there and say, hey, I know it doesn't have both of those, but this is something I believe is going to make a big difference. The evidence isn't there yet, but it's coming. I see this. And a lot of times it's going to be someone who's actively researching. So usually when people struggle with these things is they bring evidence that's not strong. And you assume that the administrators aren't going to send that to the president of the medical group, because I worked with the medical group. You're going to send it to the physicians and ask them, and if they're not a big supporter of it, it's going to die really quick without having those first two. You need strong evidence. It needs to make money, or you're going to need a major person to support it. So one of the things I always tell people, if you want somebody to support it, bring them in, make sure your physicians are fully aware, bring the bedside physicians. Sometimes your medical director may not work in the ICU, right? So if that's the case, you need to bring along some ICU docs that are really into it and want to make it happen. The next thing, I call it priming the pump. You want to make sure that whoever is in that committee that decides whether a device comes in, that you know exactly who's on that committee and you've had conversation with them. So when it hits the table, someone can speak for it. Because just like Brady said, not many people know what EIT is. I can guarantee you no one in that room knows what it is unless you tell them. So you need to make sure you're having conversations beforehand. But just sending like a couple papers that don't have strong evidence and being passionate in the department and then forwarding that to that group that's going to make the approval, it's probably not going to last there long. So that's a very
there's
blunt
essentially
response, but it's the truth.
Yeah, I used to joke that there was three things that can probably happen for you to get EIT, and it's similar to what you were saying in terms of like obviously if you have the evidence, but let's say the evidence doesn't exist. There's three magical conditions that can happen. One, you have a strong research. You have a strong research group there because many of the hospitals that have it will have a device based on research, and some of these hospitals may actually get a device sort of like loaned to them by a company for the purpose of research because they want more research published. So you either have a strong research group, two, you've bought a crap load of ventilators from the company that also sells the device, and perhaps they give you a discount on it. So that's one possible way to sort of sneak it in there on a huge purchasing opportunity. And the third one I joke is that if any VIP comes into your intensive care unit and gets treated with it, and someone's convinced that it saved their life, you're probably getting a device. Only because I've seen strange things that happen, not with EIT, but just with other pieces of equipment in the hospital. It's like, why did we get that piece of equipment? Oh, so-and-so, it's, for example, I remember hearing stories years ago of like VIP people coming into hospital getting treated with an oscillator. Next thing you know, the hospital has a budget for a new oscillator. It's because somebody with lots of money donated to the hospital and said, you guys need more of these devices because they saved my dad's life or my uncle's life or whatever. So sometimes it's just a matter of magic that you get these devices. Now, when it comes to esophageal pressure measurements, many ventilators now actually have it implemented. A typical catheter is not that expensive. I mean, in Canadian dollars, we could get a catheter for $65. That's like what, $5 US? I don't know. Obviously that's a joke. I'm over exaggerating, but they're not that expensive. So no matter your model of pricing, if your ventilator already has the built-in tool, an esophageal balloon catheter is not a huge expense on top of that compared to other things that we just open without thinking of in the ICU and just apply it to a patient's ventilator circuit or whatever.
So back to the technicalities here. So I've used esophageal manometry a lot, used the EIT almost none. And I agree with the majority of patients that we put esophageal balloons in are morbidly obese. That seems to be the approach that gets the most traction. But for sick ARDS patients, if you have the choice between using the esophageal balloon and titrating PEEP based on end expiratory transpulmonary pressure 0 plus 2 or so, or having EIT available to you, Eric, which one do you find the most utility in? And also keeping in mind that spontaneous breathing with the esophageal balloon might make things a little more complicated to interpret the data also.
Yeah, for sure. Although we put a lot of balloons in, and and this is anecdotal and commentary, clearly, I am quite surprised at the contribution of the chest wall when I didn't think it was there. right? Like outside of the morbidly obese patient, that I'm often quite surprised at it. But what I, in terms of an overdistension versus a recruitment in a non-ARDS or a non-morbidly obese patient, I think I find better value in EIT at that point, right? That they're not a morbidly obese patient, so it's not as direct, and that titration of PEEP can be a little bit tricky in terms of managing and threading the needle between preventing collapse and preventing overdistension, and where that marker lies is really just drawn out quite beautifully for you with an EIT machine, as opposed to wondering where that marker is, not being able to visualize it, right? And so if you're using a compliance or a driving pressure or an esophageal guided PEEP method, it's always in the back of your head. All right, I feel like I might be getting recruitment, but what am I doing in the process to the ventral or anterior lung surfaces with overdistension? It's always sitting there in the back of your head, and you can't elucidate it out with a lot of that, a lot of those other techniques. And so I think in the end, I pull the trigger for and strap on the EIT belt in a non-morbidly obese patient. I do both, though. And kind of get the entire data set. It's I just find more value with prevention of overdistension.
Eric, do you? I remember several years ago we talked about a patient that had the circumferential burns, and he put the esophageal balloon in and wound up on a PEEP of 40 or close to that. In patients who have circumferential burns, or patients who have, I recently used one in somebody who had significant intra-abdominal compartment syndrome, and found some utility in the numbers, the data that I was getting in terms of managing that patient.
You're talking about a balloon.
Yeah, a balloon. Yeah. Mm-hmm. So the EIT, any utility and any other extrinsic influences on transpulmonary pressure or setting PEEP?
Yeah, I mean, I think it has, I think it has the same titration of PEEP utility that you would see kind of across the board. But you do have limitations, in our burn patients. I would more than love to use it, but you can't. We're not applying it to somebody who has chest wall burns. So that's the unfortunate thing, is that all of our burn patients get a balloon drop on admission, no questions asked, whether they're obese or not. And so I don't have a really great comparison in terms of those burn patients, but the utility in an intra-abdominal hypertension, positional, I think is the same as it would be with the balloon in terms of guiding PEEP, right? You're able to visualize a collapse or recruitment of those dorsal lung segments, and get a much better regional picture than you would with a balloon, in fact, in some cases. So
I think the thing that the balloon adds to that, though, Eric, is that it gives you an idea of how high you may need to go.
Yep. Yeah.
The issue with EIT is that, for you to do a proper, compliance versus overdistension, or the Costa approach, you have to exceed the PEEP that you think the patient needs. And of course, if they have abdominal compartments, all the patients you're saying you would drop a balloon in, morbidly obese patients, like, you don't know how high to go to start your decremental PEEP trial do the EIT measurements, right? So that's the beauty. If you think the patient has significant chest wall concerns, putting that balloon in, even if you're going to use EIT with it, you at least have a ballpark of like, okay, clearly I need to put my PEEP higher than 20 if my esophageal pressure is 20 in a morbidly obese patient. I'm going to have to probably start somewhere 28, 30, if I want to get a really good EIT balance of overdistension and collapse versus, for some, if you start at 24 and your optimal PEEP is 20, you're not going to get a whole lot of data to be able to determine that 20 is you might still find 20 as an optimal PEEP, but ideally you want to capture a large range of PEEP settings when you're using EIT. And if you need to start higher, you may not be comfortable without an esophageal balloon to go up to something like 30, 35. Like we've all set PEEPs over 30 when it comes to using esophageal balloons. I would never put EIT on and start over 30 on anybody unless I knew that. Now, other things you can do, you can check things like you can check for airway closure. So a patient might have significant airway closure of 18, then you at least need to do all your measurements above 18. But again, that knowing where to start, I think, is where EIT has its limitation in terms of your comfort level. So I agree, you'll see collapse, but like how high do you go to get rid of that collapse? Yep. And if you have a balloon, you probably have way more confidence in how high you're going to go.
Yeah, absolutely. And you're right, Tom, that I probably need to start there. I mean, because they do go in together, right? And we make the point all along, because the argument, in the academic argument at the bedside, not as much anymore, right? Just because we've just been in hundreds and hundreds and hundreds of them now, and so it's a well accepted thing. But everybody wanted to point to its the evidence and say, why are we doing this? And I said, well, that's fine. You can go ahead and use the high PEEP table, and when you get to 50%, you can be on 24 of PEEP, and tell me how you feel about all that. And nobody wanted to go above 16 of PEEP without the balloon in, right? And so
the lung safe trial years ago demonstrated that nobody sets the PEEP according to the high PEEP table. Even if they say they use it, the average PEEP setting in severe ARDS patients was like 10. So clearly, and these are people that say they follow ARDSNet guidelines, right? So it's clearly not utilized. One of the things
they weren't measuring plateau pressure even.
Right?
No,
sure. The lung safe was very illuminating to me.
Oh, absolutely. One of the things, so the Palma Vista, the Drager device that I know is not available in the US, but they've actually merged these two technologies. They have a pressure pod now that is combined with the EIT device that actually you can bring in transpulmonary pressure data and esophageal balloon measurements right into the EIT device, which is kind of nice. So they've definitely have seen that these two aren't conflicting concepts, that they can be beneficial together. Oh, someone just asked that question. So I currently haven't used it. I saw it before I could even talk about it. Now it's officially available. I can talk about it. I had signed an NDA years ago that I couldn't talk about it, but it is available now, at least in Canada with the Palma Vista. But I haven't had a chance to use it because when it finally came out available clinically, I wasn't at a hospital that has it.
So Tom, real quick, what the integration of the esophageal balloon with the Palma Vista, what would be the perceived advantage of that?
Well, again, one of the things is determining a safe point for starting your EIT measurements, right? So when you have a pleural pressure readout instantly within the device, you can have that idea of like, okay, so my baseline esophageal pressures are like 20 centimeters of water. I probably need to go higher than this. So that's really one of the main deals. The other one is it allows more synchrony. So what's interesting about the Drager device, this is actually sort of a point of contention that I have with the device. When you connect it with the Medibus cable in the back, so you can connect a Drager ventilator to the Palma Vista in the back, the data is actually not synchronized perfectly. So it's off by about 232 milliseconds, which doesn't sound like a lot, but if you're doing asynchrony studies, that actually means a lot. So because you want to know exactly the point at which someone's starting to take a breath in versus when the ventilator delivers the breath. So these are some issues, but when you're using the external pressure pod, it actually synchronizes everything. So you can actually see the onset of effort with an esophageal balloon catheter and then the distribution of ventilation occurring at the same time. And there's no synchrony issues with that. Now, the Timpel device, for example, that Troy in the comments, he says he's been using it for about a year now. The Timpel device has it integrated. You have pressure flow transducer you place at the Y, just like you would with a Hamilton ventilator. So it has the pressure and flow data directly integrated in the device at the same time as the EIT measurements. So it's already set up for research in terms of looking at asynchrony and timing of of inspiration, etc. So some devices are already primed for that. The dragger connected to a ventilator sounds great. It brings in all the data, but if you're looking at asynchrony studies, you do have to perform a little magic offline. You can look at the code and you can open up your R code editor and you can reformat things so that it's at the right timing, but it's not ideal. It's for nerds. It's in order to do that, it's not easy.
Years ago when I trained, there were some that were using the bicore device. I don't know if any of you guys remember that, but
I bought one on eBay back in the
Joel
day.
Does. And there was a lot of interest in measuring work of breathing in joules. With the new sort of, I won't call it fascination, but the new interest in understanding the amount of energy applied to the lungs in terms of ventilator-induced lung injury, I wonder if anybody's really doing any serious work with looking at that again. Do any of you know if
we're all looking at PMUS now?
Yeah.
So we're not looking at the joules per minute, per liter, whatever. We're not looking at the typical work of breathing. We're using PMUS. Even in the premising study, so the premising study is a large study of pressure support versus PAV plus to be exact. And if you have a 980 ventilator or an 840, you know that PAV actually provides a work of breathing graph. And they're not using the work of breathing graph at all for targeting normal work of breathing in that study. They're using a PMUS calculator. So because of how PAV works, you can actually calculate the PMUS that the patient is generating based on the fact that the ventilator is doing a percentage of the work, therefore the rest of it is being done by the patient. So they actually have a calculator online, Covidian does, that will allow you to calculate PMUS based on the settings you see on the ventilator. So in that study, they were adjusting PAV to keep a PMUS between 5 and 10 centimeters of water. So we were using this calculator and completely ignoring the work of breathing graph. I don't know if anyone else is still using work of breathing, but PMUS seems to be and now with the POC measurement that estimates PMUS, like everything's moving towards PMUS. In fact, the drive RCT, once patient starts breathing spontaneously, they're going to be looking at PMUS estimated using a POC maneuver, which is just a single breath occlusion maneuver, validated using esophageal pressure. So again, esophageal pressure has so many uses that, a lot of people don't realize, but it's used to validate a lot of tools that we can use clinically at the bedside without it.
Well, we only have a few more minutes left. Does anybody have anybody who hasn't had the opportunity to?
Are there any questions we missed as well? I can kind of pop it up. There was some about the origin of EIT, but someone posted a Wikipedia article. Canadian companies I posted. Sorry, go ahead.
I don't know if you addressed Tim's question. It was, has anyone implemented an automatic EMR trigger that uses a mix
I
of
did see that.
body weight, PaO2, or other measures to fire off a best practice notification for the clinician? Yeah.
I'll take this. Just because we're starting down that path for a bunch of different things. Considering early warning scores for impending respiratory failure, right? An early warning score, within the ICU, that then, triggers, I think Kazmarik's group out of Mass General, 5-6 years ago, published 2 papers back to back about a lung rescue team, and identifying, it has been kind of my goal to put these tools in individually with a grander scheme of arming a lung rescue tool and then implementing an EMR early warning system for that. And so we're almost there. I got a little bit more work to do with some NAVA and diaphragmatic ultrasound pieces in terms of the toolbox for this lung rescue team, and kind of putting those together and bringing them into this entire package of, a consult team. And we've been kind of having coffee conversations about those triggers. Like when do we trigger this consult team to come, right? And I think you can say BMI, you can, and these would clearly be people that are just being monitored in an everyday garden variety type of thing, right? And so I think you look at PF and we are talking about an airway driving pressure, we're talking about a BMI, a minute ventilation to CO2 relationship, and these sorts of ideas that are pointing towards a non-optimization of the mechanical ventilation settings, right? And so, so we're toying with what those triggers exactly are going to be, but those that I mentioned are probably going to end up being those triggers, and we'll feel it out whether there's 1,000 calls or whether there's no calls, and whether we're missing the mark on these people that we want to bring in a formal consult team, because right now it's informal and it's purely organic, and it's kind of a beautiful thing to see that everybody within our critical care medicine department and across all the 11 ICUs and 132 ICU beds, they'll just call. They're like, I'm having trouble. I've gotten to this point and I've exhausted the everyday protocolized type of evidence-based medicine. Can you come give us a little guidance, right? And so that's happening, but the formalization of a EMR or aggregate data, whatever you want to talk about, and there's a lot of different, we've explored the software that's out there for it, between all of these companies that aggregate multiple software or multiple data points from multiple different devices to then alert you. And so it's this whole idea of continuous respiratory monitoring. We can't be at the bedside all the time. And how do we make sure that nobody slips through the cracks so that, the next day when they're really far behind, that's when, everybody's ringing a bell, but we missed everything beforehand. Right. And so not yet, but we are working there. Hope to get there.
I posted
soon.
a link to that lung rescue team paper because I remember reading that and thinking, oh man, I got to do this. This is great.
Yeah,
this is great.
Yeah,
it really is a great concept. And it's obviously they're looking at retrospective data versus now, there's within those limitations, it's a very interesting concept. And I really think that more people should publish like these sort of QI. It's almost like a QI project essentially, that appeared to be beneficial. But yeah, definitely.
Tom, did you see this last comment?
Yeah, is it reasonable to assume correlation between delta and expiratory lung impedance with FRC? If so, is there any data to support the strength correlation? So, this is a complex complex topic. So, FRC, in terms of measuring FRC, so when you're on ZEEP, then your end expiratory lung volume is FRC. The minute you apply PEEP, you have an added end expiratory lung volume, but EIT won't, tell you the total FRC plus end expiratory lung volume from added external PEEP. However, the delta end expiratory lung impedance, yes, that change in volume does highly correlate with the change in end expiratory lung volume. So there are studies that use that end expiratory lung volume change to calculate things like the recruitment to inflation ratio. So they can calculate an expected change in end expiratory lung volume, and then anything extra would be recruited volume. So these are mostly physiological papers. There was one study in animals that compared the slow flow inflation, like pressure volume curves used to measure end expiratory lung volume. They've compared that with EIT and found it to be highly correlated. I'm going to post a link. There's a number of ways of measuring lung volumes, and EIT is just one of them. I have a paper from years ago that I published that I don't know how detailed I got in with lung volumes, but I'll see if I talk about EIT in it. It was a while ago now, but if I do, I'll post a link to it. just need to find my.
So while Tom's doing that, I just wanted it's right at noon now on the East Coast of the U.S. So I wanted to thank everybody. I want to thank the panelists. Obviously, it's nice to have really smart, geeky friends. I appreciate all of you. I appreciate everybody who logged in to join us today. This will be available on our YouTube site, which Madison put in the comments section already. I also put our website address there. That's where you'll be able to sign up for notifications for the next panel discussion that we'll have. And so we hope that you do that, and we'll send something out really soon once we decide what that discussion is going to be about. So with that, unless anybody had anything else to add, then I think that we can call this a wrap. So
right. Thank you very much.
Thank you, everybody. Appreciate it. And again, look for the video on the YouTube channel.